Well, thank you very much, Dr. Narula. I'd also like to thank Dr. Sharma and Keeney for inviting me to be with you today and address this topic about the use of NOACs and how settled we are and whether we have a consensus around this issue. Let me just begin by reminding you of my disclosures that I'm conflicted with respect to all of the manufacturers. I've been involved in the development of each of the NOACs that are currently approved for clinical use. I would say equally so, and unfortunately for me, I have no financial interest in any of them. Let me just advance here. Thank you. First comes the question of what shall we call them? The term NOAC was originally introduced to refer to novel or new oral anticoagulants, the first alternatives to vitamin K antagonists that we had in over half a century. But they're not so new anymore, having been the first of them introduced to market more than 6 years ago, and they continue to be introduced. So they're not so new. Maybe we'll use the same acronym to say non-vitamin K antagonist oral anticoagulants. Others, particularly in Europe, favor the term DOACs, but that seems kind of dumb to us here in the US. And then there's TOACs for target-specific oral anticoagulants, but that smacks of Tsaristic Russia. Nobody seems to like that term over here. So I will use NOACs today, but you can call them what you will, okay? You're familiar with these compounds. They have entered the armamentarium. They have been a sea change in clinical practice. The first to have been introduced was dabigatran, which today is still the only approved oral direct thrombin inhibitor, blocking the last stage of the coagulation cascade as a fibrinogen is converted into the fibrin clot. That was studied in the RELY trial, an open-label study, but the only one to specifically compare head-to-head two different doses of this agent in 18,000 patients that were at relatively low risk, requiring only one additional stroke risk factor other than atrial fibrillation. Then came the study of rivaroxaban, ROCKET-AF, which was a double-blind study of about 14,000 patients, somewhat sicker, mean CHADS-2 score of 3.5, the sickest subpopulations in these trials, with a dose reduction from 20 milligrams once daily to 15 milligrams once daily for patients with moderate renal impairment. Apixaban was the next one studied in the Aristotle trial at 5 milligrams twice daily in 18,000 patients, a double-blind study as well, more RELY-like than ROCKET-like in terms of the degree of illness in these patients, the comorbidities, and about 5% of the patients received a lower dose of 2.5 milligrams twice daily, which is important to keep in mind. That means that there were fewer than 500 patients in this trial of 18,000 patients who actually received the 2.5 milligram twice daily dose of the drug, which today in the United States is about 15% of all the prescriptions for apixaban, a far higher proportion than was the case in the trial when the dose is reduced based on patient age, renal impairment, or low body mass. So whether the physicians have it right or there's this tendency to undertreat remains an unanswered question. And finally, we have edoxaban studied in the largest trial, in the ENGAGE-AF TIMI 48 trial, in two different doses. One was 60 milligrams daily, which could then be reduced or raised based on fluctuations of renal performance over the course of the study. And this study had some unique design features in terms of allowing patients specifically in and actually seeking them out with various forms of valvular heart disease and other comorbidities, so that will prove to be interesting as additional analyses come forward. And you're familiar, I believe, with the overall findings of these trials, which taken together show non-inferiority for the primary efficacy outcome of all stroke and systemic embolism. That includes both ischemic stroke and hemorrhagic stroke. And the drugs were variably effective, but all of them were uniformly at least non-inferior, and in some of the higher intensity doses, they were actually superior for that composite primary outcome of all stroke and systemic embolism. And as regards bleeding, most of them were equally safe with respect to warfarin, particularly if you consider the outcomes of major bleeding that were generally more favorable on the NOACs than were those patients who took warfarin. And the big win and the most I think, robust finding in these trials is that all of these drugs substantially and dramatically reduced the worst complication of anticoagulant therapy, which is intracerebral hemorrhage. Hemorrhagic stroke, in fact, on an anticoagulant typically has worse outcomes than the ischemic strokes we're trying to prevent, and all of these drugs showed dramatic and substantial reductions in that outcome. But the way to think about antithrombotic therapy is changing. When we make decisions for individual patients, we have to consider both the risks of bleeding and the risks of ischemic events that we are intending to present. And so the way we're starting to think about this now is changing as well. This is a bidirectional consideration, a bivariate consideration, in which you see the point estimates and the 95% confidence intervals for all of the doses tested in all of the drugs, with a greater risk of a central nervous system bleeding to the right and a greater risk of thromboembolism higher. And so the ideal location is to be in the lower left portion, reducing the risk of CNS bleeding as well as the risk of thromboembolism. And you can see that if we look at each dose of each drug used in these various trials, they cluster and overlap considerably, except for the lowest dose of edoxaban of 30 milligrams once daily, the dose that was not brought forward for FDA approval. We use a reduction to that dose in patients who develop impaired renal function, but testing that dose that could be then further reduced was the one that fell below. So these drugs, as you can see, are more similar than different when we look at the trials in this fashion. And I think we should think about these similarities. All of these drugs are non-inferior to warfarin for preventing the totality of stroke and embolism. All reduce the risk of intracerebral hemorrhage. And frankly, the outcomes with regard to major bleeding are generally better than with warfarin. Even the reductions in mortality, though there was some differences around statistical significance, were comparable at about 10%, mainly related to lower risks of cardiovascular death and fatal bleeding. There are some differences, but these differences are mostly due to variations in dosing or study design, to the intrinsic risk of the patients rather than to the drugs themselves. And in the approved doses, which vary considerably across countries, the 10A inhibitors, rivaroxaban, apixaban, and edoxaban, may be less effective against ischemic stroke than the higher dose of dabigatran. The lower dose of dabigatran is comparable to them, and the 10A inhibitors are in general less dependent upon renal elimination than dabigatran, requiring a little bit more, or let's say less caution in patients where renal function is marginally impaired. So those are about the differences. We unfortunately have a lot of uncertainties. Exactly what do we mean by non-valvular atrial fibrillation, which was the entrance criterion for these trials? And there's a host of questions surrounding the issues of various subgroups that we encounter in day-to-day practice. The elderly, patients with diabetes, patients with moderately impaired renal function, patients undergoing cardioversion, a great deal of struggle around what to do in patients who require antiplatelet therapy concurrently because they are undergoing revascularization of the heart, patients undergoing ablation where studies have been relatively small and limited, whether in the cath lab or the EP lab or in the cardiac operating room, what to do with atrial fibrillation that is detected in patients with implanted devices, what do we do in patients who've had a previous brain hemorrhage. These are all questions that the studies themselves were not designed to adequately answer. And we have concerns as clinicians as well. How do we decide when to use warfarin versus a NOAC? Which NOAC should we use? Because in the end, we have to prescribe one or another if we choose to go down that path. We should remember that not having to monitor coagulation intensity, the INR, for example, on a routine basis, doesn't mean that we can let these patients go off into the sunset. We need to keep an eye on their renal and hepatic function because those greatly determine the exposure to the drugs. And the fact, frankly, we asked for something and we're not so sure that we really wanted it. We said, we don't want those blood tests, but now we have situations where we're insecure. Has the patient been taking the dose? Is it the right dose? Are they protected enough? What about drug interactions? They don't seem to have mattered in the trials, but there are a good deal of interaction that could influence the concentration of these drugs. And frankly, there are situations where we need to know how anticoagulated is that patient before they go in for an invasive procedure, for example. And we wish we had a way to measure the intensity of anticoagulation, but we have no approved assay here in the United States for any of them. We also said we don't want these drugs sticking around like warfarin does for a week. We like the short half-life, but remember, warfarin is forgiving. If you don't take it on Thursday, no big deal. But how about with these NOACs, where the anticoagulant effect dissipates very rapidly? Again, we asked for something, but I'm not sure we always wanted it. There are some contraindications, and the labels would indicate that in form of valvular atrial fibrillation. But what is valvular atrial fibrillation? What do we do if patients should develop bleeding? Because until recently, there were no actually tested, proven reversal strategies. And finally, these are extremely expensive drugs that average about $8 to $9 a day for therapies that will be required over the course of a lifetime. And that becomes a matter that all of society must be concerned about. These are the current guidelines, and they differ somewhat in various venues. I'll show you the European Society of Cardiology guidelines that were just revised about 2 months ago, just at the time concurrent with the annual meeting of the ESC, and the ACC, AHA, HRS guidelines, which are currently in the course of a development of a focused update that I hope we'll see within the next few months. Patients have no risk factors. They have a CHADS-2 VASC score of 0, then neither of the guidelines recommends antithrombotic therapy for patients who have no additional risk factors. When there's one moderate risk factor, the CHADS-2 VASC score is 1, the Europeans suggest that we consider anticoagulation, and in the US, the recommendation is against antithrombotic therapy. The threshold may change as the NOACs become more part of our routine practice because they can be delivered more easily and perhaps more safely than warfarin. Once we get up to CHADS-2 VASC scores of 2 or more, there's uniformity about the need for an anticoagulant, but the Europeans explicitly favor the NOAC. Here in the US, there's more equipoise, and of course, for patients with mechanical heart valves, only a vitamin K antagonist is in the game. When we don't have evidence and we don't have guidelines, that doesn't mean we don't have opinion and recommendations, and there's a host of recommendations out there that are not evidence-based, but are beginning to pervade practice, and I'll mention some of them. Let me just cover a couple of the issues. What about non-valvular atrial fibrillation? Well, the original warfarin trials that showed that it made sense to anticoagulate patients with risk factors excluded patients with mitral stenosis due to rheumatic heart disease, but didn't specify how bad the mitral stenosis needed to be. We also excluded patients with any kind of prosthetic heart valve, even a bioprosthesis, and we didn't even consider the issue of valve repair these decades ago. But that's a kind of an area where there's no reason to think that anticoagulation wouldn't work the same way with a NOAC in a patient with mitral stenosis. We just don't have any data, and we have very limited data around biological heart valves. The Europeans have now banned the term non-valvular atrial fibrillation, and they've pointed out that it's true that in patients with mitral stenosis, we don't have any evidence, so we can't use it necessarily there, but in other kinds of native valve disease, aortic valve disease of any kind, mitral regurgitation, we don't have to consider those. They may be treated with NOACs just as they would with warfarin. We're not quite so sure what to do with bioprosthetic heart valves, but the evidence is beginning to come along. But the Europeans are no longer using that concept. They exclude mitral stenosis, they exclude mechanical heart valves, but that's as far as it goes. These are data from the ENGAGE trial of edoxaban. They have been reported but not yet published. 191 patients with bioprosthetic heart valves in that trial, and as you can see, the risk reduction for thromboembolism in that study was just as favorable, if not more so, with edoxaban compared to warfarin as it was in patients without bioprosthetic heart valves. And there are a number of studies now that have shown similar patterns with patients with valve repair. So we're beginning to loosen up a little bit. The European Heart Rhythm Association has said that in patients with mechanical heart valves, you should not use a novel agent or a NOAC. In patients who have moderate to severe mitral stenosis, you should consider that treatment contraindicated, but they allow it for milder forms. In patients with other valvular disease, no problem. In patients with severe aortic stenosis, not much data, but no real contraindication. In patients with bioprosthetic valves, wait at least 3 months after the valve is inserted, and then you can go ahead with a NOAC based on opinion, not on science. Mitral valve repair, they recommend waiting even a little longer, again, without much evidence. And for patients undergoing transcatheter aortic valve replacement, again, the recommendation is it's okay, but again, we lack data, similar in other situations involving hypertrophic cardiomyopathy. What about cardioversion? We now have about 3,700 patients in secondary type studies that have gone on, one with rivaroxaban, the XVERT trial, and a recent one for edoxaban, the ENSURE AF trial, and compared with a vitamin K antagonist. These drugs were associated with low rates of the efficacy outcome of thromboembolism in the pericardioversion period, and the incidence of major bleeding was also similar to that with drugs like warfarin. The time to cardioversion is not changed if you use an image-guided approach, but in patients who get the conventional approach, given a vitamin K antagonist, it takes on average 9 weeks to have a therapeutic INR for 3 consecutive weeks, whereas with the NOACs, if you're taking it, you're therapeutic on day 1, so you can greatly accelerate the time to cardioversion. But when you're not using image guidance, you really need to be careful about whether patients are consistent. My first patient in this, I remember going up to the EP lab right before she went for cardioversion, and I said, "Have you been taking that dabigatran?" And she said, "Absolutely, yes, I've been taking my pills," and whipped out the bottle of metoprolol. So be very careful because we have nothing to measure here. There are still some uncertainties around cardioversion. One is, can we use these drugs safely when patients require urgent cardioversion? They're either hemodynamically unstable or when we have a duration of atrial fibrillation that's, say, less than 48 hours. And what do we do about patients in whom we find thrombus in the left atrial appendage? We have very little data yet on the outcome of patients in whom thrombus was present when the NOACs are used as opposed to warfarin, heparin, or conventional anticoagulants. Some of these questions will be answered by ongoing trials. The EMANATE study, now data lock occurred this morning in our EMANATE trial. These are patients with newly detected atrial fibrillation, typically arriving in the emergency department, who for the most part are getting TEE-guided cardioversion randomized to apixaban versus usual care. And now we will finally begin to get some answers to what happens to those patients in whom thrombus is found on TEE as they continue treatment with the standard practice or apixaban. So we begin to get some answers there about acute AF and about this issue of thrombus. Let me now turn to the matter of patients undergoing PCI or those who've had an acute coronary syndrome who require typically dual antiplatelet therapy, but also an anticoagulant because of atrial fibrillation. We know the antiplatelet drugs are not going to provide advantages that are substantial enough for patients with atrial fibrillation, and that an anticoagulant is not going to be protective against stent thrombosis or coronary ischemic events in patients with an acute coronary syndrome. And this impossible to understand diagram comes from our colleagues in Europe, based really on opinion, and I don't think particularly helpful, so nobody really knows what to do in this kind of situation. Patient gets a drug-eluting stent, they have atrial fibrillation and a CHADS-VASc score of 3. What do we do with concurrent therapy? The trials are coming. The first one is Pioneer AF-PCI. This study is done. Results are expected next month at the American Heart Association Congress, and you're going to see these are complex trials. Patients are randomized. A period of dual antiplatelet therapy is specified prior to randomization, and patients either follow the standard of care, which is to take a vitamin K antagonist plus dual antiplatelet therapy for that period, followed by warfarin and then low-dose aspirin, dropping the the P2Y12 inhibitor. That's what we're supposed to do according to the guidelines. Or in this case, they were randomized to a very low dose of rivaroxaban, much less than we use for atrial fibrillation during the DAPT period, followed by a higher dose of rivaroxaban and aspirin alone. And a third so-called Wust-like arm with 15 milligrams of rivaroxaban and clopidogrel or another antiplatelet agent that continued all along, eliminating the aspirin. And these studies are all designed to look at the outcome of clinically relevant bleeding. We'll have results and finally a bit of guidance, but look at the number of changes in strategy that occur here. It's going to be very hard to choose a path that is necessarily best. And then when the next round of studies come, here's one with dabigatran, again a 3-arm trial with aspirin usually eliminated when the NOAC is used, and comparing again to a vitamin K antagonist. Now we have another 3 strategies to look at, and when we go to the one with apixaban, there are 4 arms. Aspirin with, aspirin without, going back and forth between these drugs. Now we'll have literally 15 or 20 different treatment algorithms. There will be no way that we can generate evidence-based guideline recommendations. We need to get this together a little bit better, but at least we'll be getting to get some experience about how the NOACs fit into that scenario. And coupled with these trials comes very valuable large registry trials, 50,000 patients or more, spanning the globe, where we can get practice-based evidence. You know, we've always considered the randomized trial the gold standard, the polished gem of the evolution of clinical science. The problem, of course, with randomized trials is that 90% of the patients that we see in clinical practice are not eligible for those trials because of comorbidities or one thing or another that keeps them out. So practice-based registries that are highly inclusive, if they're well done, are not a substitute for randomized trials, but they complement them and help us understand how we can gain insights into the epidemiology and practice patterns, particularly around questions like how accepted are NOACs today and when are we using them, and they enrich our experience in patients with these comorbidities that are typically underrepresented in trials. Just as an example, the Gloria AF registry with dabigatran, this is over 10,000 patients during the early phase of introduction. This is while there was still a kind of an inception pattern occurring, NOACs still new, and you can see that in fact as that period went by, almost half of new prescriptions for patients with atrial fibrillation entering the anticoagulant game, if you will, or the antithrombotic arena for the first time have now become the NOACs. About a third continue to be warfarin. And amazingly, still too many, I think, are receiving aspirin or no therapy at all, even amongst relatively high-risk patients. So overall, we're still looking at nearly 20% of patients with risk factors for thromboembolism and atrial fibrillation beginning to be treated with respect to stroke prevention, receiving what we would largely consider to be ineffective strategies for stroke prevention. And this represents a field that contains the most preventable form of the most disabling strokes. So it's an opportunity lost that we should bear in mind. I want to take a moment before closing just to talk about where we are with reversal strategies. This has been a huge impediment to the wider use of these drugs in clinical practice. Until recently, all we could do was use non-specific procoagulants, fibrin donors, if you will. PCC, prothrombin complex concentrate, a factor VIII inhibitory binding antibody that we can use, FIBA, or recombinant factor 7A. But these are all nonspecific. They cannot be expected to immediately counteract the anticoagulant effect of a target-specific agent. In normal subjects, we have the greatest experience with PCC and FIBA, mostly with the 10A inhibitors, very little experience, relatively speaking, with dabigatran. And the problem with these approaches is that when we give high doses, they actually increase the risk of thrombosis. This is the true chemically induced prothrombotic state. And so these patients may not be bleeding, but they'll turn around and get a venous thrombosis or even an ischemic stroke too often. So this is an unsatisfactory, frankly, under-evaluated approach. And I'm happy that we're beginning to see some specificity entering into this area. We have now the approval of idarucizumab, which is an FAB antibody fragment that specifically reverses dabigatran. There are another set of approaches called andexanet alpha, which is a decoy factor 10A blocker that can be used to interfere with the anticoagulant effect of all of the 10A inhibitors, but that's not yet approved for clinical use anywhere in the world. The FDA just this past August, decided to delay approval. There are some manufacturing issues, and it's a bit more complex. There's another one called serapantag, which is still in phase 2, which is capable, at least in preclinical studies, of antagonizing and blocking the anticoagulant effect of every oral agent and some of the parenteral agents except warfarin. So we will still be stuck with fresh frozen plasma and vitamin K for warfarin, but we may have a universal reversal agent for anticoagulants, but it's going to require a good deal more to develop. Here's where we are. The only one yet approved is idarucizumab. It's a fantastic reversal agent for dabigatran in under 5 minutes with 2 amps injected, 5 grams of idarucizumab. You completely reverse the anticoagulant effect of dabigatran, and the next day the effect of both is typically gone, and you can re-anticoagulate the patient if you want to. And andexanet alpha, a bit more complex, takes about an hour to prepare for administration, and there may be a need to redose with different dosing strategies for each of the 10A inhibitors. And as I mentioned, there are some manufacturing issues, so we're hopeful that we'll have approval next year, but that's not certain. And serapantag is still in phase 2. So right now, only one of these agents has a demonstrated reversal strategy. And that's something that we'll see whether that will translate into different patterns of clinical use. Let me close by saying that these NOACs, if you think about the efficacy of warfarin compared to placebo and realize that these drugs are at least as effective as warfarin, makes them amongst the most effective medications for any disease. The likelihood of having an ischemic stroke when you're taking a NOAC, even as you would with warfarin, is very, very unusual. We hardly see ischemic strokes, people taking these drugs in therapeutic doses. But the best evidence favoring their use over warfarin relates to avoiding intracranial hemorrhage, and that's the main driver of the improved survival and the main driver of net clinical benefit. And we have to be careful about conditions that are associated with changing renal or hepatic function. I would be very cautious about off-label use. We saw what happened in the Realign trial, mechanical heart valves with dabigatran. It was a disaster, more bleeding and more thromboembolism than with warfarin. We should be careful about using it shortly after an invasive procedure because there is the concern about bleeding and relatively less risk, I think, on a day-by-day basis of thromboembolism related to atrial fibrillation. Be careful about concomitant antiplatelet therapy until we see what happens in some of these PCI trials, and we'll have that information soon. And the reversal agents are coming into the arena, but we may end up using them relatively infrequently. We are changing the way that we think about this field. The use of these NOACs will doubtless increase, but optimal use requires comparative studies and the more widespread availability of effective reversal strategies. The individual NOACs are more similar than they are different, and we should frankly focus as physicians on assuring that patients who have atrial fibrillation and risk factors for stroke are identified and appropriately anticoagulated with something, and rather than get too worried about which agent that we choose, because frankly the real challenge is that too many people with atrial fibrillation receive no antithrombotic therapy at all, and there's an opportunity before us to prevent thousands of strokes. Thank you very much for your attention.